So I have two talks, and I think what we decided was to just break after each of them, because one is just general schizophrenia treatment, oral treatment, the other one is LAIs. There are a couple of new studies we should take into consideration, also particularly with regards to some of the quality indicators, polypharmacy, and we'll go through that. I, like Roger, am in contact with a number of pharmaceutical companies. We believe, I think, both that we need the financial muscle from the pharmaceutical industry. They need our expertise so that we get novel mechanisms. This is not the topic of the talk, but we recently published a paper looking at all of the potential novel mechanisms for schizophrenia. And there are a little bit more now in the pipeline, at least, than we've had in the past. But let's see whether they can make it through phase 2 into phase 3 and approval. So basically, we'll talk briefly about treatment goals, and then the acute treatment first and multi-episode maintenance, taking out the LATs, and then talk about side effects. Just briefly, as you know, we are better at achieving response in patients, and always better with first episode patients than chronic patients. Remission already gets a little harder to achieve. That's mild symptoms or less for no more than 6 months. And then recovery is the hardest, so getting people into functionality. But one of the biggest roadblocks to this, where also, although first episode patients do better in the beginning, they don't for recovery anymore because we have too many relapses. So one of our main targets is actually to keep people in treatment. And that's where risk-benefit ratio comes in. That's where long-acting injectables come in. Because these many relapses when patients are off treatment are then bad for the illness course, but also we breed secondary treatment resistance. And that's where we really need to focus, not only on the acute, but the maintenance treatment. So let's start in the first episode. This is from an earlier meta-analysis where we would say, especially in the first episode, do not use first-generation agents. Second-generation agents have only a small advantage, but they do for negative symptoms, depression, and cognition. But they have a larger advantage for keeping people in care, both altogether, also for intolerability related reasons, but also for efficacy. And this is a larger difference for keeping people in care than for the symptoms themselves, because to rate symptoms, there was no difference. You need people to come back. So you have a bias of survivors on first generation agents. But those, when you take everyone who should come back, and non-responders are the ones that, or people where you know they drop out because they have inefficacy, they are counted here. So you're basically 30 to 40% lower risk of dropout on second generation agents, even for inefficacy. Now, a network meta-analysis that was done subsequently also supported that haloperidol is suboptimal to second-generation agents, but second-generation agents amongst themselves are relatively equal, so therefore we need to base our treatment more on the side effect differences. And we would basically say mostly the same for the chronic patients. Who are the super responders? When you treat them, it's the ones that are treatment naive, more than the pre-treated. It's females, those with higher acuity and severity, where you have actually room for improvement, higher age at illness outbreak, so obviously the younger people are, when they have the illness, the worse, and shorter illness duration. So we need to get people into care as early as possible. At least minimally improved in first episode patients, over 80%, and much or very much improved, which is a 50% reduction or more from baseline, it's 52%. And we'll compare that to chronic patients in a minute, seeing that the more chronic a patient is, the more you lose the gain. So what you want to use early should be safe and effective so that people can continue it, and ideally also considering long-acting injectables so that you make visible when people stop the care. Now, medications alone are not good enough. We need to combine that with psychosocial interventions. This is a meta-analysis showing across 10 studies and 2,000 patients that a combination of antipsychotic treatment with 3 to 4 other psychosocial interventions, case management, supported employment and education, psychoeducation, group or individual psychotherapy, has on all 15 meta-analyzable outcomes better outcomes than for people who are just in irregular care, where the team members don't talk to each other and where there might be more fragmented care. And for symptoms, we have only small effect sizes. Remember, a fifth of a standard deviation, 0.2 is small. Half of a standard deviation, or that's an SMD or Hedges G, or is always the same for continuous outcomes. A fifth of a small, half is medium, and 0.8 is large. We have only small advantages for symptoms, but these are again people who come back to be assessed. When we look at everyone randomized, then we have moderate at least advantages for integrated care, for less discontinuation, 30% less discontinuation, 26% risk reduction of at least one hospitalization, 29% reduction for relapse, 29% improved outcome for remission, and even the elusive goal of recovery, functional and symptomatic improvement, still 24% greater chances of achieving that. Now, lower chances of being back in school or work, but in almost all of the meta-analyzed studies, the supported employment and education part was small or absent. So we need to get symptomatic improvement, but then rehabilitate the heck out of these people and wrap care around them. Now, we're currently meta-analyzing the 3 studies, and we're analyzing our study as the 4th one. What happens when you stop integrated care and move them then into regular care? Usually most of the gains are lost. So this myth of a critical phase of the illness of 2 years, you put everything in and then you pull back, most likely doesn't work. But that shouldn't surprise us. If you have hypertension and you're stabilized after 2 years, we wouldn't say, well, yet now remove it because you're stable. So we most likely have to keep the psychosocial intervention, but maybe not as a kitchen sink approach, but rather seeing what modules have these patients graduated from and are pretty stable, and where do we put the emphasis so that we have more like a step-down approach. Another very important paper, also since the last guidelines, address the question, how long should you treat people with first episode? You know that the guidelines generally say 1 or 2 years. Why is that? Because that's when the RCT evidence ends, continuing versus non-continuing. So people have said, okay, then maybe after 2 years you can stop. But that's like saying, well, out of 10,000 meters or 30,000 feet, you shouldn't jump out of a plane without a parachute, but what about 20,000 feet? Maybe you can. So here is a database study where you have 100% of enrolled patients, and Jari Tihon looked at basically over 10 years of care in Finland and set as the reference of risk for hospitalization or death people who got medication prescribed and picked it up. So people who didn't have any use had 100% greater risk. Patients who took medication for 3, 6, 9 months and then stopped had the same risk as if they had never taken anything. People who took it for a year and a half, and then stopped had the same risk as if they had never taken anything. So the protection is lost when you stop. But then when people stop between 2 and 5 or after 5 years, something strange happened. Rather than the risk going down as we would have hoped for, or what would motivate to say now you can stop, the risk didn't stay the same, it went up. Why is that? Well, remember, this is a non-random assignment study, treatment selection. It's called basically confounding by indication. Who would you or I continue as a first episode patient on long-term care? These are the ones that have insufficient response, very poor psychosocial outcomes, and when they then stop, boom, they are the higher risk patients. That means also that here, obviously, we have an underestimation of the relapse on no use, because some of these people in the database that are clinical care patients might not actually have had psychosis, that is schizophrenia, and didn't need long-term care. So that's a little watered down. But at least based on this, and that is 100% of patients in care, there is no safe time when to stop antipsychotics. That is relapse or death. But let's look at death itself. When you have people who take antipsychotics, or at least pick it up from the pharmacy for 3 years continuously, fortunately their death rate is 12.5%, relatively low, although the biggest suicide rate is in the people who have insight and basically then get depressed. So the people where you say, wow, they're doing well, for themselves they realize I'm not doing well enough and they might kill themselves. But people who are not picking up the medication have a threefold higher risk of death. Patients who take it for a year, great, they're protected. But then if they stop after 3 years, they've lost all the protection. Yeah? So continuation of care is most likely the name of the game. What about chronic patients? Another important study has come out recently that replaced the 2013 meta-analysis, network meta-analysis by Leucht. This is also Stefan Leucht's group. Now we don't have 15 antipsychotics and 215 RCTs and 40,000 patients. We have 32 antipsychotics, 400 RCTs and 50,000 patients. But basically the gestalt remains the same. Remember, this is not a head-to-head meta-analysis. It's a network meta-analysis where the impossible is being achieved, meaning you are creating a hierarchy across all antipsychotics, although the most of them, as you see in the perimeter, have never been compared against each other. How do you do that? You create indirect comparisons. If A is much better than C, B is only a bit better than C, then A must be better than B. But that only works when everything is the same, and over 60 years of research it has not remained the same, especially our main comparator, which is placebo, indirect, because every medication on the market has to have 2 positive placebo-controlled trials. Placebo has gained 12.5 points in PANSS improvement over the last 45 years, drug 1.2 points. So that means all of the meta-analyses, network meta-analyses, show newer agents, the newer atypicals more at the bottom and the older atypicals more at the top. But be it as it may, if you're colorblind, you can't appreciate it. The newer network meta-analyses at least are a little bit more honest. They add color to the 95% confidence intervals, meaning red, okay, it's there, but we don't trust it. It's either too small or there are other issues. In general, the effect size across all studies has remained the same, 0.4, 0.41, which is similar to effect sizes in medicine. Most of the 95% confidence intervals overlap, and it goes from 1/4 of a standard deviation to maybe 2/3 of a standard deviation. Clozapine still looks very good, although this is somewhat biased by one study of 22 placebo-controlled patients who had an effect size not of 0.2, 0.5, 0.8, 1.6, and then everybody looks weaker than that. And that's interesting, and you will see how vulnerable meta-analyses are to outcomes. Here, clozapine looks the best, whereas in the meta-analysis I'll show you for treatment resistance, it doesn't even separate anymore from 3 atypicals, although these are supposedly resistant patients. Be it as it may, the differences are relatively small in efficacy. The 95% confidence intervals overlap mostly. The authors themselves say that efficacy differences are, quote, gradual, unquote, and mostly not statistically significant, whereas side effect differences are much more large and also significant, and we'll get to that. Here we have now the chronic patients, again something that was published maybe after our guidelines. Minimal improvement only 50%, much or very much improved 1/4. Look what happens when you allow people to become chronic and have relapses. So our initial improvement in first episode schizophrenia drops dramatically, which again speaks to the fact that relapse prevention should be our name of the game. So let's go to resistance. This is from another development in the meta-analytic world. You may know before it was head-to-head meta-analyses where at least the groups were truly randomized. Then we have network meta-analyses where you put everything in. Now we have umbrella reviews, a review of reviews, meta-analyzing in effect meta-analyses. So what we did here was looking at 29 meta-analyses and 42 combination strategies in 380 studies and 20,000 patients to ask the question, what should you do when monotherapy with an antipsychotic doesn't work? And to our big surprise, we found 14 strategies that seemed to be really better than monotherapy, with effect sizes that were small, medium, large, or extra large. And some of them very well known to you, but maybe you hadn't yet noticed that they should be so great. For example, as NRIs, 1.3 effect size, that is basically venlafaxine and duloxetine. Then some agents you and I have never heard about, serotonin 3 receptor antagonists, adenosine modulators, azopiones, and then some others where we haven't been overwhelmed, lamotrigine, even NSAIDs, that is mirtazapine or miranzarine, estrogen, lithium, minocycline, topiramate. I elevated topiramate to another recommendation because it's pretty robust now, at least the meta-analyses, but also NSAIDs and acetylcysteine, modafinil. So we asked ourselves, how is that possible that there are these nuggets that clinically we haven't found to be as effective? And so what we did was we said, okay, maybe these meta-analyses are. So we used the AMSTAR scale and rated them, and fortunately, because at least 15 of these meta-analyses are mine, they were all very well done. They are well done because we have guidelines for meta-analyses, and we always took the latest and the greatest, and they have to really have all these check boxes. Great, so the meta-analyses are done very high quality by high quality people. So we thought, what's the problem? What about the meta-analyzed studies? So we created a new scale, the AMSTAR Plus, the content scale, and that's where things fell apart. The meta-analyzed studies were bad. Most of them were small, and they pushed the evidence in one direction, and the largest study never confirmed what the other small studies pushed in one direction. And the negative small studies are not being published. And there are other issues, how the things are, how the original studies are analyzed, only taking completers and so forth. So we found that the quality of the evidence was low, and the lower the quality, the higher the effect size. So we felt most likely these treatments have to all be taken with a grain of lithium, and we can't really recommend them. But let's take some closer look at one recommendation or one finding that would be counter to our quality indicator, and that was 2 antipsychotics are better than 1. Where do we have that? Antipsychotic polypharmacy. It should come total symptoms. Anyway, 2 antipsychotics. Oh yeah, 2 antipsychotics did not make it for total symptoms, but I'll show you what happened. So basically, clinicians are right. 2 antipsychotics work better than 1. When the clinician knows it and the patient, all of the effect sizes are in favor of the augmentation because there's this very nice bias. In randomized trials, half of them are to the left, half of them to the right, and instead of a 0.8 very strong effect size, we have a non-significant effect size. These are still people who come back. What about treatment response? Again, when people know that they're on 2 agents, 30% better response, statistically significant. But when nobody knows, basically like 1. There's no difference whatsoever for 2 antipsychotics over 1. There was a high quality finding though when you add a partial agonist to a full antagonist, aripiprazole was the only one studied, then there was better outcome for negative symptoms. Maybe the atypical, that is a partial agonist, is very tightly binding, pushes the antagonist out of the way, and that's an indirect advantage, or it could actually be the partial agonism. But this seems to be, in blinded studies, they're all to the left, a fairly good and dependable outcome, although it's just 4 studies, obviously. Another augmentation for negative symptoms, this is our meta-analysis, we've done another one, is antidepressants. That's pretty robust. There are at least 6 or 8 meta-analyses. When you add an antidepressant to antipsychotics, you do get a negative symptom advantage. So the question then is, well, are there some patients, so you could say the people here in the open label studies, this is just bias, but you could also say in open label studies we get patients who are truly resistant to get someone to agree to a double-blind study, maybe we're selecting out people who are not truly resistant. So the sickest of the sick might benefit. And there's some indirect evidence of this from this randomized trial by Susan Essek, where people who were on 2 antipsychotics were either, but unfortunately not blinded, open label, switched to stay on 2 or go to 1. And the first finding is 70% of people can be converted to 1 antipsychotic. They didn't need to. They're fine. But there's some worsening and discontinuation on 1 and on 2, and that difference is like 18% or so. But they knew there might have been more anxiety in these people who said, oh, I can't tolerate it being just on 1. So we need a blinded study. But I think the first finding is most people will not need to, even in an open label setting. But there might be some difference that there's a subgroup that benefits more from 2 than 1. And we need to at least follow up on this. And we need to follow up on this because of this finding, which is interesting, and I'll repeat that in the LAI sample because this shows that long-acting injectables in a database study, 30,000 patients, 100% generalizable, that out of the 10 best treatments, mostly are LAIs, but the 2 oral ones that are on top are not only clozapine, it's also polytherapy. That means 2 antipsychotics. And this is in the hands of clinicians. So I didn't believe that, so I talked to Jari Tihon, and then we actually looked at data from Finland and found the same thing. This just came out in 2019. Look at the best 10 treatments to prevent hospitalization. Only 1 is monotherapy, and that's clozapine. All the others are combination treatments of more than 1 antipsychotic. And when you look at the best 15 treatments, it's basically only 3 monotherapies, clozapine, an LAI, and olanzapine. All the others are combination treatments. However, which ones? That's important. The only one that beat clozapine was adding aripiprazole to it. And all the other combination treatments either have clozapine or an LAI in there. Olanzapine is only better in combination when you have it together with an LAI or clozapine. So when you use the giants that we should use in refractory patients, either an LAI or clozapine, and they don't work, maybe then you would want to invite polypharmacy. So we might want to be a little bit more graded in that approach. Now, quetiapine in monotherapy doesn't work at all. It needs to be combined, but it might be the other way around because quetiapine is added on and might help a little bit with sleep and anxiety and depression. Because here we don't know what is the first one and what is the augmentation agent. Even risperidone, basically only better when you add an LAI, clozapine, and here maybe olanzapine. But it means that for some combinations, there may not, in clinical care, if you can't use clozapine, adding them to an LAI might be helpful. So it's just showing you it's not all black or white, at least. We also discussed in this paper, maybe what's happening is that people, as they're improving, you want to switch, and then you get a regression to the mean, they improve, and you keep people on 2 at the moment when they have improved. And that's like a hangover, basically, and it's a marker of that they have improved and can improve on treatment. And if they don't, then you stop both. It's tricky, but there are at least now data to look at polypharmacy not only as a disadvantage. Well, we looked at treatment refractoriness and found that out of 42 studies, 21 only used criteria, and out of those 21, only 2 studies used the same criteria. Those were 2 studies from the same group. So we said we need to create a working group and redefine TRS, and we did, basically restating a little bit the old CAME criteria, at least 2 antipsychotics given each for 6 weeks and 600 milligrams chlorpromazine. That makes it at least 12 weeks altogether. We want at least moderate severity, but we also harped on we need to have at least adherence. So in the optimal description of treatment resistance, either do we want blood levels or at least 1 treatment with an LAI to make sure that people are that they are treatment resistant. And this is the puzzling finding that clozapine is better in TRS meta-analyses than first generation agents, but not better than olanzapine, risperidone, and even ziprasidone. Now, why is that? If you had to design a study and you want to show that you're as good as clozapine, and obviously these companies wanted to show that they're not worse, what would you have to do? You can do two things, and one is the most effective. You preordain the outcome. So if you're in the ring with Cassius Clay and you don't want to be beaten to death, what do? You beat their hand behind the back. So you give clozapine a dose that's low and yourself a good dose. And that's happened here. Only Janssen did studies where risperidone was compared in some studies with at least 450 milligrams of clozapine, and then clozapine beat. So these meta-analyses are also suspect to criticism, and also if not all patients are refractory, but some are non-refractory, you also might not see that difference. So we were really irked by this, wrote an editorial to it, were invited because I was also a reviewer of this paper, and pointed out some of the issues. But then we said, let's do a meta-analysis, and that just came out in October now, this month, or last month. Let's look at patients who are more generalizable, and these are cohort study patients where the clinician decides, do I give clozapine or not in patients who might be more refractory. And even though patients were significantly sicker in the clozapine arm, there was still lower hospitalization risk, better treatment outcome. So in generalizable samples, clozapine is better than non-clozapine, and but the problem is that you also can create more side effects, including the number needed to harm to get one more diabetes patient is 27. After each 27th patient you start on clozapine, you might get one more diabetes patient. But diabetes is manageable, treatable, and untreated illness of the psychotic nature actually kills people even more. But then the question is, how quickly and when should you use clozapine? We, despite these data, said at least 2 trials. Actually, if you treat me, I want you to give me 4 trials, although I'm the last author of the guidelines that we should do it after 2 trials. Why 4? Because let's look at this study. 75%, this is Ofer Agid from CAMH, the study where they had a very nice algorithm, 4 weeks low dose, 4 weeks medium dose, 4 weeks high dose, and found that, yes, first episode patients respond. Either risperidone or olanzapine, no problem, 75%. Then patients were switched over, and you see that the treatment response drops to only 16%. And then when they went to clozapine, it went up to 75%. So people have now been saying, should we not just have one trial with a first-line agent, and if there's non-response, not intolerability related, poor outcome, go right to clozapine? I would say no, please not, because 16% means 1 out of 7. That is 2.5 people here in the room do not need clozapine lifetime. And even if I'm on, haven't responded to risperidone or go to olanzapine, 1 out of 4 will not need clozapine. And even here, that's 1 out of 26. So basically almost 1 out of this group will be spared clozapine if you give them another 6 weeks. What is 6 weeks in the lifetime of someone who is sick for 60 years? And actually I want 4 trials because we don't know which agent will work. But I want you to give me after 8 months, because it's 6 to 8 weeks per treatment, you have me on clozapine, not 8 years. And I think we shouldn't empty the baby with the bathwater. But here's another study where the conclusions emptied the baby with the bathwater. This is the optimized study. Here, the outcome in first episode patients is not response, but remission, meaning no more than mild symptoms. 4 weeks of open label treatment with amisulpride gives you a very nice remission rate after just 4 weeks, 56% overall if you take everybody in account. Then there's a 6-week additional randomized treatment, keeping in red amisulpride or switching to olanzapine, and there's no difference. However, the remission rate drops from 60 to 30. And then after 4 plus 6, 10 weeks, they get another 12 weeks of open label clozapine, and we're not back at 56%, we're now down to 20%, from 1 and 2, 1 and 3, 1 and 5. Okay, so This is remission though, and it's only 22 weeks of lifetime treatment. But what did the authors do? You should never do that. I don't know why Lancet allowed them. The reviewers were not on their tiptoes. They said for most patients in early stage schizophrenia, symptomatic remission can be achieved using a simple algorithm, sequential administration of amisulpride and then clozapine. Since switching from amisulpride to olanzapine didn't help, skip that step. Wait a second, you never studied this. We don't know whether adding clozapine here would have been helpful. Because patients are so early in care, it might still have been the case that everything is the same. Also, had you waited a little bit longer and really had treatment non-responders to amisulpride, then maybe olanzapine would have worked. And your wonder drug, clozapine, is only at 18%, which is clearly worse than the 34% of olanzapine. What are you talking about? Yeah? So be careful even when you read Lancet papers, because people have their opinions and that color the results. There is, though, a meta-analysis again thinking, could we skip step 2 and go right to clozapine? For me, who cares? 6 weeks on something that is so much less side effect laden, why not? We're not talking 6 years difference. And as you know, even clozapine has only a 40% only quote-unquote response rate. So it's not the panaceum, which is why we also need to look at augmentation strategies. We've talked about that maybe once clozapine doesn't work, you can add something to it. And we've meta-analyzed ECT co-treatment, and that, as we have it in the guideline, is currently the best evidence. Adding ECT to clozapine has better response and remission, both early on at 1 and 2 weeks and also later. And if you look at here, study-defined response and remission, we have very strong effect sizes with very nice and respectable number needed to treat. We come to adverse effects, the last couple of minutes. I think since I told you that I believe that maintenance treatment is the most important part, we need to give treatments that don't minimize quality of life. Because when people have less symptoms but feel their quality of life is impaired, they will not continue care. And when you ask family members, they say that sedation, weight gain, and EPS, anticholinergic effects, so cognitive dulling, are the most life-impairing side effects. I mean, patients don't talk much about sex with their parents, that's why you don't see it here. That can also be impairing. Then, when you look at Rogers' paper, not asking family members sedation, weight gain, cognition, but asking patients, then you see basically weight gain, somnolence, and cognition. So we want to most likely avoid these side effects because they are very much related to non-adherence. EPS, metabolic side effects, prolactin elevation, and sedation. So having safer agents is important, but also for psychiatric outcome. Roger mentioned it. This is another study where out of 34 risk factors for relapse, only severity of illness was one that was independently related, and the other one was metabolic syndrome, with a 1 to 10% greater risk of severity of illness, but a 10 to 740% greater risk of relapse when people have metabolic syndrome. So we want to keep that down, maybe oxidative stress, inflammation. And this is from a paper we have currently under review. Like in bipolar disorder, as Roger mentioned, metabolic syndrome, diabetes, maybe also obesity and overweight associated with poorer cognition. So we're also impairing cognitive functioning. Last 2 slides. This is now the gradation from the network meta-analysis. I don't want you to see the exact medications, just the gestalt. It's very clear for dopamine blocking related side effects. EPS, akathisia, prolactin. Further down is more different from placebo. We have the first generation agents and the don'ts. Whereas on top we have the partial agonists and the penes, because they have inbuilt histaminergic and anticholinergic effect. Reverse that picture when we have sedation and weight gain. At the bottom we have the penes, because they have sedation and weight gain, and at the top we have the partial agonists and the don'ts. So the partial agonists balance out the side effects the most. And for QT prolongation, we have 5 safe medications that are not worse than placebo. The 3 partial agonists, A, B, C, aripiprazole, brexpiprazole, cariprazine, lurazidone, as well as paliperidone. Okay, so this is the oral paradigm. I think we need to get safer agents into the patients early on so that we can keep them long-term on the medication, and we'll talk about the LAIs in a minute. For resistance, clozapine is still the name of the game. Some combinations might be helpful. Again, I elevated topiramate next to lamotrigine, so glutamatergic modulators, since that's most likely the missing piece, but clozapine and LAI should be favored first. Thank you.